دكتورة رشا ودكتور أحمد، حضراتكم كو هوست، تقدروا عن طريق الستارت ويبينار ايكون يكون احنا كده لايف.
يعني ابدا البودكاست.
نبدا برودكاست ونقعد
زي
كده
ما حضرتك حابب.
ما نتكلمش لحد ما الناس تتجمع، بس هنبدا
تمام. اوكي، انا هدوس على برودكاست. احنا دلوقتي هنستناهم يتجمعوا شويه وبعدين نبدا.
اوكي.
رشا واحمد، ازيكم؟ عاملين ايه؟
ازي حضرتك؟
انا كويسه الحمد لله الحمد لله.
Okay, good evening, everybody. I'm just looking at my screen at the participants, so giving a chance for everybody to join. Just a few seconds more. Okay. I think now. Welcome to our bi-monthly scientific meeting for the Pediatric Clinic of Qasr Al Aini. Today, we're very honored to have Dr. Lubna Khazbak as our moderator, and I hope you'll enjoy the cases that we have for you tonight. We're going to start by Dr. Sara Maher, who will be telling us about a few cases and what we should do next. So, Sara, if you can share your screen, please.
It's my pleasure to share my 3 cases with you today to benefit from our two: normal anterior segment, normal intraocular pressure, normal pupil, and bilateral normal fundus. The picture in the primary position in the middle one, showing large angle mild narrowing of the severe upshot of the left eye with mild narrowing of the left palpebral fissure, and the same occurs in the left gaze in the right eye with much less upshot. So my diagnosis was a case of bilateral Duane type 2 with upshot more in the right than in the left, more in the left than in the right eye. Sorry, it's written بالعكس. It's Duane type 2 because we have more limitation in adduction than in abduction with the upshot. Also, there's an upshoot in the right side. So it's a bilateral exotropic dwane with bilateral upshoot. Okay. It's repeating. First, when I met this case, I thought on difficulties. The first was measurement of the angle of deviation. The accurate measurement of the angle of deviation with alternate prism and cover was a bit difficult. And as the eye gets an adduction, the upshoot makes the accurate measurement very difficult. But the estimated angle was about 65 prism diopters. Then my surgical plan was, my main aim was to correct the deviation in the primary position and to correct the upshoot. What is the surgical plan? I decided meters with Y spetting to release the tightness on the lateral recti, but this would not be enough to correct this large angle of deviation. So I added medial rectus resection, about 5.5 on that. This would solve the problem or make it much less. These are these first post-operative photos on the first week post-operative, hypertropia, meaning some upshoot more on the left side also. This is photos 3 months post-operative is more evident. It's about 16 prism diopters hypertropia, and there is also residual or recurring XT in the primary position, more in the near than in far. It's about. So the question here was next. What can I do now in order to give the patient better alignment? I started to revise some things that made me more aware of the types of upshoot in dwane retraction syndrome. We have two types, either the mechanical type and the innervational type. The mechanical type, due to the leash or the Bradley effect, بيبقى في sudden slippage of the tight lateral. What I did for him to release the upshoot is just while splitting rectus and the superior rectus or the inferior oblique, and sometimes there is a mixture of both. In the mechanical upshoot, there is sudden abrupt movement as the eye moves from abduction to adduction. However, in the innervational type, the deviation increases gradually as the eye moves from abduction to adduction, and usually there is a straighted coexisting vertical deviation. So our patient most probably has a mixed type of both the mechanical and the innervational type of upshoots. We only tackled the mechanical type. And also what I learned was the grading for the upshoots. This way help us to grade the upshoot in the straight line parallel to the intermediate canthal line is drawn from the pupillary center. If this line bisects the pupil, there is no upshoot. If it is lie between the pupillary center and the pupillary margin, is grade 1. Right eye, which is a great degree of upshoot that should make me think from the start that will not be only released by simple wide splitting of the lateral recta. We have type in the pupil normal fundus, but the vision in the right eye was normal 6/6, while in the left eye was only counting fingers 50 centimeters. She suffered from deep amblyopia. These are the pictures of the patient. She has left exotropia with hypertropia, but from the assessment of divergence, it seemed that the right eye has a limited elevation in all gazes, in adduction, in dead primary position, and in abduction. But the depression is normal, while there is limited elevation of the right eye. So my diagnosis was that the problem is in the right eye. She has a right monocular elevation deficit, but as she prefers fixation with the right eye, there is secondary hypertropia in the left eye. Again, what are the difficulties when I met this case? Measurement of the primary angle of deviation is very difficult. The patient is always fixing with the right eye, so I couldn't measure the primary angle. All what I could measure was the secondary angle of deviation, which was about 25 prism diopter, left hypertropia, with an exotropia of 35 prism diopter. So the question now, which eye to work upon? Whether to work on the amblyopic eye or on the eye with the primary problem, the right eye. And my surgical plan was to perform force reduction test first before surgery on the right eye. If there is positive force reduction, I would perform inferior rectus recession. This is what I did. It was mildly tight, not severely tight. I performed inferior rectus recession, right inferior rectus recession of 5 millimeters, and I performed left recess resect on the left eye to correct the exotropy. Sorry. Sorry. And this was her post-operative photos. These are the first week post-operative. She's more or less accepted appearance. The exotropia disappeared, but there's small left hypertropia. And this 3 months post-operative, still left hypertropia, which is significant. So what's next? Returning back to the pre-operative photos. Okay, sorry. Returning back to the pre-operative photos, I noticed that the left eye showed limited depression somehow in adduction and in dead down position, which means that the superior rectus most probably was tight, and this is what I missed during the primary surgery. I should have performed the force reduction test also on the superior rectus, and maybe this would have corrected the whole vertical deviation. So I think the next step is to perform left superior rectus recession, force reduction on the left superior rectus, and perform left superior rectus recession. While revising in the literature, I found that this was already mentioned by Dr. Ahmed Awadain in his paper, that he found that combined inferior rectus recession and ipsilateral inferior rectus recession and contralateral superior rectus recession in cases of binocular elevation with tight inferior rectus give the best results. So this may have solved the problem from the start. But the question, which angle shall I work on the secondary, the numbers, and I don't have a primary angle of deviation, all what I have is the secondary angle. So should I have divided the secondary angle between the inferior rectus and the superior rectus on the left side? This is a question to my professors. The third case, and this is the last one, is a 55-year-old male presented with right esotropia 2 years ago. He has history of hyperthyroidism, which was treated medically. Then he did thyroidectomy 2 years later. He's controlled since then regarding his thyroid state. He has no diplopia. He did only the surgical history was a history of bilateral cataract surgery and IOL implantation 5 years ago. He has a best corrected vision, right eye 0.3 and the left 0.7. Anterior segment show posterior chamber IOL, uncomplicated cataract surgery. His intraocular pressure was a bit high, so he was on timolol and it was controlled. He has a round regular reactive pupil and the fundus was digroid with tilted disc. These are the photos of the patient. He presented with this right esotropia. It was about 40 prism diopter in the primary position. The versions show -4 limitation of abduction in the right eye, with a -1 limitation of abduction in the left eye. Otherwise, the versions are normal. So at this point, I was doubting the diagnosis. Is this just a thyroid eye disease with marked affection of the right medial rectus? There is no proptosis, there is no lid retraction. I was doubting the diagnosis, but when I saw his imaging, orbital imaging, he had thickened recti with tendon sparing. So it is a simple case, or it's a straightforward case of thyroid eye disease for me when I saw these imaging pictures. So what I did was a force reduction test. I found it extremely tight, and I performed bimedial recession of 6.5 millimeters, a bit more than the usual tables for 40 prism diopters of esotropia. But the surprise on the first day post-operative, that's upon the patient the same as pre-operative. He had even, all missed the same angle of deviation. He has the same right ET with the same limitation as if I did nothing. And this is photos for 6 months post-operative. He has the same very large angle of esotropia, the same 45 prism diopters with the same degree of limitation of abduction of the right eye, -4. So could it be something else? I start to think again and again. And I thought the patient has no diplopia, although the esotropia was acquired only 2 years ago or 3 years ago after the onset of hyperthyroidism. This was the history. So I thought that he's pseudophakic. I couldn't have his actual refraction. So I decided to perform an ultrasound to check for the exit lens. I found that the exit lens in the right eye was 31 compared to 25 in the left eye. So I thought again, could it be an heavy eye syndrome? with this marked limitation abduction and esotropia. I started to revise the criteria for diagnosing heavy eye syndrome, which is progressive esotropia and hypotropia with limited abduction elevation. As we all know, بيبقى فيها inferior displacement of the lateral rectus with medial displacement of the superior rectus, either due to degeneration of the lateral rectus superior rectus band or supratemporal prolapse of the staphyloma. And these were the criteria. And I revised the dislocation angle, which is defined as angle between the centroid of the lateral rectus and the superior rectus and the centroid of the globe, and this assumed to be a right angle. However, in cases of heavy eye syndrome, it's more obtuse, may be very large and very obtuse. So I revised his photos again, the MRI photos. Sorry. I started to, I know that the cuts are not the ideal cuts for detecting this dislocation angle, but what the impression is that there is only medial displacement of the inferior rectus. I couldn't judge actually from his photos whether this could be considered heavy eye syndrome or not. So my question to my professors, should I order new MRI with special cuts, and what should I order from the radiologist to get accurate information? Could I do a repeat force reduction with re-recession or transposition or Ikema procedure? Which option should I pass to? Thank you very much, and I hope we benefit all from the discussion. Thank you.
Thank you, Sara, for the interesting cases. Dr. Lubna, would you like to comment?
اوكي. احنا نسينا الحالات كده، كان المفروض نناقش في الشد نناقش كل حالة at the same time, but however as regards to the first case, bilateral Duane retraction syndrome, exotropic type with very large angle, I think the decision in this situation is depends upon the positivity of the force reduction test on the lateral recti. If it is very tight lateral recti, you should consider not only recession of the lateral rectus muscle, but disinsertion and suturing the muscle to the periosteum on the more affected side, which is going to correct the large deviation, not only the recession. Also, after doing recession, you should, before ending the surgery, you should repeat the force reduction test. If it is still positive, you consider disinsertion of the lateral rectus muscle. As regards the resection, we do resection in Duane retraction syndrome in certain situations. If the retraction of the globe and narrowing of the palpebral fissure is not very marked, about 1/3 of the position in the primary position, and you can measure the width of the palpebral fissure in the primary position and in adduction, and see how much the narrowing and the retraction is. If it is 1/3 retraction, you can do resection. If more than that, resection will add more retraction and more narrowing of the palpebral fissure. So resection is okay if there is no severe retraction and if there is no marked upshoot or downshoot. The residual upshoot or downshoot may be due to innervational factor, and you can differentiate between innervational factor and tethering effect. The leash effect, as Sara said, it is abrupt. Also, if you let the patient look a little bit down, there is also downshoot, not only upshoot. This is sure sign that it is a leash effect. But the innervational effect, you can judge if it is a smooth elevation. Also, you have to look at the fundus. If there is extorsion, then it is the inferior oblique is responsible. If no torsion, you cannot tackle the inferior oblique muscle. If there is associated DVD, maybe the superior rectus is also involved, so you can solve the problem with the superior rectus muscle. But doing horizontal surgery with vertical muscle as a superior rectus, there is a high risk of anterior segment ischemia, of course. So in this situation, maybe the upshoot, as we see, it is very abrupt, so it is due to the tethering effect. If Sara did this insertion of the lateral rectus and suture it to the periosteum, I think this was going to improve the upshoot and also improve the large angle of exotropy. Anybody else has any opinion in that case? Dr. Ahmed?
Right. I agree with you, Dr. Lubna. I don't think that I have anything to add. Just for the record, there is always the option of transposing the superior rectus towards the medial rectus in some cases of exotropic Duane syndrome. If you want to correct the residual exotropia, I don't have enough experience in doing the medial transposition. We usually tend to do the lateral transposition in esotrophic Duane, but it has been reported that it might work in some cases to correct any residual exotropia in Duane syndrome, in exotrophic Duane syndrome.
But if you do recess resect with superior rectus, this carries the risk of anterior segment ischemia.
Yeah, but usually we do it without the medial rectus resection. We do the lateral
Yes.
the superior rectus transposition, because usually in Duane syndrome, I mean exotropic Duane syndrome, not the classic type 1, I mean the type 2. The main problem of medial rectus resection is not because it will increase the narrowing. The main problem is that it is usually not as effective as in cases of straightforward exotropia. Usually it loses its effect after some time and you end up with recurrence of the exit deviation.
Okay.
I just want to ask about if طبعا are we expecting to have a very good result, because if this patient is left with some hypotropia, would he start to complain of diplopia? This patient has always had one eye, it's always fixing with one eye at a time, and then we perform surgery, and for us the surgical results looks very nice, but for him it's not 100% perfect because there may be some minimal vertical element. Will he complain of diplopia?
I think Sara's case, one eye is severely amblyopic and no diplopia.
Okay.
As regards the
weird because he's alternating. There's nothing to explain why he's severely amblyopic in one eye, and I think there was another case which couldn't be explained why they're severely amblyopic in one eye.
Most probably he fixates more with one eye than the other. I think so.
Sara can tell us what was the cause of amblyopia, Sara?
In the first case, the Duane case, I think the constant deviation, this eye was constantly deviating. He prefers always the right eye, so the other one gets amblyopic, strabismic amblyopia, because of the long-standing deviation.
Okay.
And the second one, the same, the monocular elevation patient, she doesn't have anything to explain her amblyopia except the strabismus. She preferred fixation with the right eye at first. The other one gets secondary hypertropia, and it remains so for 13 years, so she got amblyopia.
Okay.
As regards the second case of the monocular elevation deficit, doing force reduction test on both eyes is very, very important.
Yes,
especially
and this is what I missed.
Yes, she's fixing with the right eye, and the left eye is hypertropic. And as you see, you said and pointed in the pictures, there is a limitation of depression of the left eye, which is most probably due to tight superior rectus from the long-standing hypertropia. What to do in this situation? You should relieve any positive force reduction test. You should, any contraction, you should relieve it. Otherwise, the situation will not improve. So, I think the proper solution is to recess the superior rectus of the left eye until the force reduction is becomes negative, and this will solve the problem.
Regardless of the numbers, Dr. Lubna, I mean the measurements, regardless of the numbers.
You can do relaxed muscle surgery. You can do relaxed muscle surgery. You recess it, hang back until we repeat and repeat with bow tie and repeat the force induction test. Once it becomes negative, you stop recessing.
Okay.
My question about superior rectus recession is that it is very hard to overcorrect the patient, because in patients with vision deficit, the heart recording line. So even if you did a liberal, a large contralateral superior rectus recession, it's very hard to get an overcorrection. That's why you can do large numbers like 8 and 10 millimeters, and you won't be afraid of getting any problem.
Okay.
Innervational muscle surgery, it would even increase the innervation to the eye with the monocular elevation deficit, and this might help to improve the elevation.
Okay, thank you.
And also improve, you are not going to need to do NAP procedure in such situation.
Okay, thank you.
There is also something recently published in monocular elevation deficit, in which they do something like what we do in Duane syndrome. They do an inferior rectus recession, and then they transpose either the medial or the lateral rectus muscle to the superior rectus. So it's like a single muscle transposition, not
Ahmed, we don't hear you.
Can you repeat it, please?
Sure, sorry, I got disconnected. You can do it like a single muscle transposition. You transpose either the medial or the lateral rectus to the superior rectus, combined with an inferior rectus extension. The good thing about this is that there's little risk of anterior segment ischemia, because you're working only on two muscles, the inferior one of the horizontals. And the other good thing is that it can correct large angles. For example, if you have like 25 and 30 prism diopters, you can correct a large angle using this single muscle transposition.
Okay.
If the patient has some horizontal misalignment together with a monocular elevation deficit, which is not uncommon in many cases, you have like a monocular elevation deficit with a small ESO or exo, you can decide which muscle to transpose based on the horizontal alignment. For example, if you have an esotropia, you transpose the medial rectus
and recess it a bit.
Reduction. And if you have an exotropia, you transpose the lateral, and this will correct part of the exotropia.
Okay.
But transposing a recessed muscle has a weaker effect than if it is not recessed. So take care of this. It depends upon the angle of deviation, the primary position. If you need large transposition, large recessions, then the transposed muscle effect is going to be much less.
Yeah. Either way to measure the primary angle in this case, yani I couldn't, but I don't know either the way to measure the actual angle of deviation, or it doesn't matter, yani the secondary angle with
the restriction, it's not a big deal.
Yes.
You have to get out the limitation by relieving the restriction. This is the most important point.
Okay.
Ahmed, you want to add something?
No, I mean, if you are planning to do the contralateral superior rectus, or the superior rectus on the hypertrophic side, then it is what you are measuring is good, because you are measuring the secondary angle, and you are working on the superior rectus, which is correcting the secondary angle. So it will be more important than the primary angle, even in this case.
Yes, okay. Thank you, dear Professor. The third one, but the most important.
The third one. The third one. I tried the finger test done by the Fabre, but I failed in cases of heavy eye syndrome. Have anyone tried it and succeeded in that instead of the MRI? Ahmed, you tried it?
No, I only had one patient after the Fab mentioned this, but it didn't work with me.
Yes, the same to me. I had the similar case, Sara, of case with history of thyroid eye disease and very large esotropia, and she's pseudophakic and almost immetrope. With marked limitation of abduction and some limitation of elevation. So when you can't tell if it is heavy eye syndrome or not, but if you look at the fundus, although you don't have the previous refraction of the patient, if you look at the fundus, you are going to see myopic degeneration. Yes. The myopic fundus, and I had the fundus examination for this patient, and I saw myopic degeneration. So I realized that it's a very high myopic patient, and I sent her to do MRI, which proved that it is a heavy eye syndrome and not related to the thyroid ophthalmopathy. The muscles were not so much enlarged as your case, but there is muscle displacement. In your case, maybe it is difficult due to the marked muscle enlargement as seen in the MRI, but you should be sure that the cuts are about 8 millimeters from the 8 cuts from the optic nerve junction.
Okay.
To get the centroid of the muscles and to measure the angle. If you can't do that due to the muscle enlargement, I think you should explore the area or between the superior rectus and the lateral rectus. And if you see herniation of the globe in this area, you can do Yokoyama procedure.
Okay. Thank you, Dr. Lubna. Thank you, Dr. Ahmed, Dr. Rashid. Thank you very much.
Anybody, Dr. Hatem, are you with us? Dr. Hatem, can you add something? Hatem Saeed? Most probably he's not listening. Ahmed, do you want to add something?
Well, just from the MRI, I got the impression that it's probably like a thyroid rather than a heavy eye syndrome. And I think it might be combined with like myopic esotropia rather than a heavy eye. Sometimes in high myopia, you got this like strabismus fixus. So it's probably like a double pathology of myopic strabismus fixus with a dysthyroid eye disease. And both of them would require a very liberal and large amount of redirected recession. I would probably, for myself, I would do a large recession like 8 or 11 millimeter on a hangback suture so that I can revert it. And it is very hard to get an overcorrection in such patients with marked limited abduction.
Okay. Thank you. Thank you, Dr.
Lubna and Ahmed. We move on to Asmaa. Asmaa is going to show us a case of Helveston Triad. You can share your screen, please.
Okay. So you can see it now?
Yes, we are. Put it on slideshow, please, Asmaa.
Okay. Okay, حاضر. ثانية واحدة. 1 minute.
Okay.
Good evening. It gives me a great pleasure to present you. Okay, so it gives me a great pleasure to present you today this case of Hilliston Triad. By examination, here we have a male patient, 36 years old. He has right XT since childhood and no history of previous surgeries. On examination, he has best corrected visual acuity of 0.2 in the right eye and 6/6 in the left eye. So he has right amblyopia because there is no significant difference in the refraction between both eyes. The rest of the examination has shown that the pupil is rounded, regularly active in both eyes. He has right ptosis and normal fundus in both eyes. So in the primary position, he has right exotropia of 85 prisms, and the head was showing a right head tilt. So on the side gazes, the side and upwards gazes, he has no inferior oblique overaction. But here we have bilateral superior oblique overactions that is well seen. So regarding the pattern, he has an A pattern exotropia. Here we have the A pattern well seen, the downwards position, the primary and the upwards position. He has bilateral DVD, so when he fixes with the left eye, the 6/6, the eye with the vision 6/6, he shows right DVD. And when he fixes with the right eye with the amblyopia, the left eye shows DVD. So the 3-step test has shown no significant difference in the angle or no hypertropia seen. So let's see the photos of the patient again. Here we have right XT of 85 prisms, and this is the upwards position, and the downwards position we have an A turn XT with bilateral superior oblique overaction. So this patient has XT with an A pattern with bilateral superior oblique overaction and DVD. So what is the diagnosis and what is the type of the surgery you are going to do for this? Actually, when I saw the patient, I did not know the diagnosis and I was directed towards the horizontal deviation and the superior obliques. So I consulted Dr. Ahmed Rida and Dr. Dina Hussam, and they told me that this is a Hilliston Triad and it has a certain type of surgery to do. So the Hilliston Triad was first described in 1963, and this is the Helveston himself in a photo with Dr. Had Said 10 years ago. So for the bilateral DVD, I've done bilateral superior rectus recession of 6 millimeters. And for the A pattern and the superior oblique overaction, I've done the bilateral superior rectus posterior tenectomy, the superior oblique posterior tenectomy. And for the XT, I've done bilateral lateral rectus recession 9 millimeters with right medial rectus plication of 6 millimeters. So I reduced here the numbers that are needed for this large angle in order, because I've already weakened the superior oblique muscles and it's one of the abductors. So, so weakening this type of muscle may add to the effect of surgery of for the XT itself, and I might be having an overcorrection of the angle. And I've done plication and not a resection because I've done surgery in lots of the muscles and I was afraid of the anterior segment ischemia. And all of these procedures were done through a superior temporix incision. So regarding the tips and tricks of the surgery, I asked Dr. Hala Al-Hilali about this. So first of all, we will expose the superior rectus muscle and cut any connections between it and the levator palpebrae superioris in order not to have a retraction of the eyelid while after the recession. And after that, you will elevate the superior rectus muscle and cut the frenulum between the muscle and the superior oblique. Do the tenectomy, and after that, you can cut the intermuscular septa on either sides of the superior rectus muscle and do the recession. Regarding the tenectomy, you will leave about 1/5 or 1/4 of the muscle only, and the rest of it will be cut. So what are the results of the surgery? The head tilt improved so much, and the patient, these are the pictures of the patient 2 weeks post-operative. Regarding the horizontal deviation, it's almost also. And now let's see the different positions. This is the primary position, in the upwards position and the downwards position. So the A pattern improved a lot and the horizontal deviation improved a lot. But here we still have superior oblique overaction that is seen in here. But these are the photos of the patient 2 weeks post-operative. So what I did is the classical management of this triad, which has disadvantages mentioned. After that, the weakening of the superior oblique and the superior rectus may result in reversal of the pattern of the deviation and correction of the exotropia together with all of these muscle surgeries may lead to anterior segment ischemia, and there is a risk of eyelid retraction. So an alternative was suggested after that is the full oblique muscle weakening surgery, which is doing the horizontal deviation. And after that, we will do bilateral superior oblique posterior tenectomy with inferior oblique anterior transposition, as it was suggested that the oblique muscles play a role in the etiology of the DVD. So Hilliston Triad is not really that so common, and its management involves surgery on multiple muscles. Thank you.
Thank you, Sara. Sorry, thank you, Asmaa. Dr. Lubna.
I think in one of the pictures there is some underaction of the right inferior oblique muscle. Did you notice that, Asmaa? Ahmed, did you notice that?
Yes,
No.
what is the DVD?
Yes?
Maybe this is caused by the DVD because the Asmaa patient has some DVD. So maybe when she looks on the side, there is a contralateral DVD, so it looks like an inferior.
Maybe. So duction version was very important to see if the superior oblique overaction is secondary or primary, if there is actually inferior oblique underaction or not. So as regards this situation, I do prefer the foreoblique muscle surgery because there is less incidence of anterior segment ischemia, especially are going to operate on the two horizontal muscles. So it is better to do for muscle surgery instead of the superior rectus, which is going to correct the DVD, the superior oblique overaction, and the horizontal exotropy. Anything else?
Thank you.
I want to ask a surgical, maybe surgical advice. How can we make sure that when we do the tenectomy, we are doing it like symmetrical, or is there a way that we know that that we are doing it equal on both sides? Are there measurements that we can take? Because post-operatively, he obviously had one eye was markedly improved while the other eye was much less improved.
Well, when
Yes.
you do tenectomy, it is possible to end up in disappearance of superior oblique overaction. Usually the patient after posterior tenectomy has still superior oblique overaction. It is a weak surgery. It does not reduce the superior oblique function that much. And usually you have some residual A pattern and superior oblique overaction. But the good thing about it is that it avoids any overcorrection because we are afraid of doing a complete tenectomy or doing something more than this. You end up in something like a V pattern esotropia or double vision in down gaze, which is very hard to correct later on. So it's a weak surgery, and this is the good thing about it. It's like a wild way to reduce the.
Would it be better if we performed, like Dr. Lubna said, to perform surgery on the Sorry, Ahmed, can you go back and repeat it because الصوت قطع معلش.
Sure, because I got a phone call. Whenever I got a phone call, I get disconnected. I'm sorry. Well, I worked with Guyton for a while in 2006. He was the one who proposed the foreoblique muscle surgery, and he was at first when he started doing it, he thought that it was very encouraging and the results were good. And then he himself said that the results started to recur again, the recurrence of the DVD. So he started refraining from doing it. But personally, I don't have experience with full muscle surgery. I would do the classical surgery, in which we do the superior rectus recession and the posterior tenectomy. I would do a more aggressive posterior tenectomy than what usually do, like 90 or 95% removal of the posterior fibers. I only leave like a very tiny anterior strip, like 5% or 10% of the thickness of the superior oblique. That I would like to mention that your patient Asmaa had a very large, and usually I expect this patient that he will develop later recurrence of the exotropia. So I tend to do a larger surgical dose in what you did. Probably I would do like 4 muscles for an 80 prism diopters exo. I would tend to do like 4 muscles rather than 3 muscles.
Can I ask a question?
There is recent studies which prove that the oblique muscle surgery is very effective. Recently, yes.
مساء الخير عليكم. معلش انا يعني كان بس سمول كومنت.
Yes.
الحقيقه انا في انا دخلت على الحاله دي بقى للاسف ما حضرتش اول حاله. يعني اول سبيكر ساره اظن للاسف ما حضرتهاش. انا حضرت التوك بتاعت اسماء. انا ليا كومنت بس ان الحاله اللي فيها superior oblique over action غالبا هيكون فيها كمان معاها inferior oblique under action bilaterally, and that's why ده السبب الاول ان انا ما برجحش اعمل inferior oblique anteriorization. السبب الثاني ان انا ما لقيت بصراحه في نسبه عاليه قوي من الريكارنس اوف دي في دي مع الانفيريور اوبليك سيرجري. I would go for superior rectus recession bilateral. وحتى لو انا خايف من anterior segment ischemia I can fractionate the story. يعني ممكن اشتغل الاول على الهوريزونتال ديفيشن. انا ليا كومنت برضو ان بالتالي السيرجيكال دوز اللي اسماء استعملتها اقل شويه من واتس نيدد. I can يعني increase the dose شويه. وبعدين ممكن اعمل at the second session البايلاترال superior rectus recession ومعاها السوبيريور اوبليك بايلاترال posterior تيناتومي.
هو ال surgical dose for the horizontal deviation, I used a smaller surgical dose because I had already bilaterally overactive superior obliques, and I thought that this might contribute somehow to the degree of exotropia. So if I weakened these overacting muscles, I will end up with a less amount of exotropia. Yani the actual exotropia after weakening these muscles is not that much. So I told myself I'm going to do a less amount of correction, and if he has a residual, I can do it in another surgery.
What about inferior rectus tucking in this patient? It will help in reducing the exotropia and down gaze. In addition, this patient has mild ptosis. Doing superior rectus recession in a tosed patient may increase the ptosis appearance. Isn't an inferior rectus tucking on both sides is a good option in this case or not?
The good thing about inferior rectus tucking is that it corrects both the
down gaze,
and also because being an adductor, it will correct part of the apex.
Part of the exotropia, yes.
Yeah, so theoretically it is a wonderful surgery, but practically, whenever I do it, I always regret doing it. I usually end up in recurrence of both the DVD and a quick recurrence of the A pattern exo. I did it a lot, but I have very
نظريا شكل يعني هتصلح حاجات كتير.
لا بس يا سارة
theoretically it would work, practically it doesn't work. Even with a large amount of tucking, I do like 8 and 10 millimeters tucking, not just 4 or 6 millimeters, but it doesn't work for me. I only do it for like hypertropias of 4 or 5 prism diopters, never more than this. It doesn't work for more than that.
Okay.
At least in my hands.
هي سارة
دكتور حاتم
هي السبيرو ريكتس ريسيشن هتعمل upper lid retraction مش توزس.
Retraction, yes.
هتعمل upper lid retraction عكس التوزس. دي هتصلح التوزس مش هتزوده.
هتصلحه؟ ممكن انا فكرت بالعكس. اوكي. Thank you صحيح.
One thing about the large angle, about the superior oblique effect on the horizontal angle, usually
yes.
very large angles like this, like 80 prism diopters, the more common outcome is getting an undercorrection, especially over the long term, because this patient had a large angle exotropia over years and years. So whatever you do, like lateral rectus resection and medial rectus resection, they tend up to build up recurrence of the exotropia. You will be amazed that you will come a few months later with like exotropia 30 and 40 prism diopters again after a while. What you are talking about is the classical exotropia like 30 and 35 prism diopters. But for 80, so this is a very large angle. And one thing that you have to remember that when you have two prisms, for example, a 40 prism diopter on the right side and a 40 on the left side, they don't add for 80, they add for like 90 or 100. Optically speaking, the sum of the two prisms is even more than the simple algebraic sum. It's more than that, like 90 or 100 prism diopters.
انا برضه يعني عايز برضه ازود كومنت بسيط. انا بالذات في الحالات الكونستنت اكس تي مش الانترميتنت اللي فيها very large angle, I have practiced for a long time ان اعمل شويه an odd approach. انا بعمل bimedial resection with one lateral rectus resection, and it can give a very good result with a larger angle. فيعني I can achieve even overcorrection sometimes, a slight overcorrection.
Okay. Are you here, Dr. Hannah? Would you like to add anything? Dr. Hannah? I'm not sure she's here. Okay.
لا أنا موجودة. I'm here.
Would you like to add anything, Dr. Hannah?
Can you hear me?
Yes, sure.
Yes.
طيب okay. أنا بس كنت يعني I think this is a great way of treating the triad. I would do all three at the same time. But and also because it allows you to work very well on the superior oblique because you're detaching the superior rectus. But for DVD, I would go more than 6 millimeters recession. So I would maybe do 8 superior rectus recessions. And as you said, I don't think that a superior oblique tenectomy would really correct all that A pattern and all that superior oblique overaction. I do a recession of the superior oblique on both sides equally, and this works better. Thank you.
Thank you, Dr. Hel. Okay, we'll move on to our next speaker, Dr. Rehab. She has a case of glaucoma and DVD.
Until Rehab shares her presentation, would anyone will consider elongation of the superior oblique instead of recession or tenectomy in such case? Tendon length elongation for weakening the superior oblique?
To make the surgery very long, because you are now talking about 4 or 3 horizontal muscles, 2 vertical muscles, and 2 oblique muscles with elongation. It would take like a couple of hours to complete the surgery.
Yes. Just because of the timing?
Yes, and you still will be afraid of getting some V pattern esotropia because now you have weakened both the superior rectus and superior oblique. So there's a high risk of getting a V pattern esotropia.
Okay.
And Ahmed, can you just, while Rehab is getting ready, tell us, tell the audience why we left a few fibers of the superior oblique. I know it's for the torsion, but maybe you can explain to the audience why we leave these fibers, these anterior fibers.
Because it's supposed that these anterior fibers what protects your surgery from getting the esotropia and the excyclotorsion in the anterior fibers are what are responsible for the abduction in down gaze, and they are responsible for the encyclotorsion. So if you weaken them, you will get an esotropia in down gaze and you will get an excyclotorsion. And remember that you already weakened the superior rectus, so you will get an addition, an effect of both the superior oblique weakening and the superior rectus weakening. So both of them will contribute to a large esotropia in down gaze and a large excyclotorsion in down gaze. So by preserving the anterior fibers, you maintain this effect of the superior oblique on down gaze.
I just wanted the audience to know. I think Rehab is ready.
See my screen?
We can see your screen here, Rehab.
I'm presenting a case of juvenile glaucoma with this presented a surgical challenge for me. As an introduction, juvenile glaucoma is an inherited form of glaucoma presenting between 4 years of age to early adulthood. So it presents after the age where the globe can enlarge. Dissociated vertical deviation is eye elevation, abduction, and extorsion when binocularity is disrupted. The classical treatment of DVD is superior rectus recession if there's no inferior oblique overaction. And the classical treatment of DVD with inferior oblique overaction is J deformity, inferior oblique anteriorization. However, it was reported that DVD without inferior oblique overaction can still be treated by J deformity, inferior oblique anteriorization. The inferior oblique originates here near to the lacrimal fossa and is inserted at the posterior temporal part of the globe over the macular area. This is the normal inferior oblique anatomy. Accordingly, as the inferior oblique is inserted behind the equator, when it contracts, it presses the back of the eye, so it elevates the front of the eye, so it causes elevation. And also, as it's inserted behind the equator on the temporal side, when it contracts, it adducts the back of the eye, so it abducts the front of the eye, so it causes abduction and extorsion, which is the main function of inferior oblique. In J deformity, inferior oblique anteriorization, the anterior and the posterior poles of the inferior oblique are sutured in front of the equator in level with the inferior rectus muscles. So it creates a form of a J deformity of the inferior oblique. If the inferior oblique now is inserted in front of the equator, it will depress the front of the eye and not the back of the eye. So its action would turn into depression. The description here, I'm presenting a 5-year-old boy with ocular deviation. The mother complained of ocular deviation since birth, and she gave complaints suggestive of a visual field defect. She said that the child would think that the staircase ended and would trip over and fall, and that he can see very small objects right in front of him, but not bigger ones at the periphery. So by listening carefully to the history from the mother, I suspected glaucoma. And this gives the message that history taking is very important. Actually, this boy was referred to me from a glaucoma specialist just for having strabismus, and he missed the visual field defect complaints, and he missed that the child had glaucoma in addition. On examination, the child had bilateral mitosis. He had DVD, bilateral DVD, intermittent exotropia, A pattern, inferior oblique overaction bilaterally, and normal inferior oblique actions. So the lids had bilateral mitosis, and the extraocular muscles had bilateral DVD more in the left eye, exotropia of 60 prism diopters, and A pattern, and bilateral +2 superior oblique overaction. So he had the Helveston Triad of DVD, superior oblique overaction, and A pattern exotropia. In addition, he had a compensatory chin depression, as the angle of XT was much less up due to A pattern, and he had normal inferior oblique overaction. The vision was 0.2 and 0.4. Cycloplegic refraction showed compound hypermetropic astigmatism. And juvenile glaucoma was diagnosed by an intraocular pressure of 24 in the right eye, 28 in the left eye. The cup disc ratios were 0.2 and 0.4, which were not bad. And the corneal diameter was not enlarged, so it was not infantile glaucoma, but juvenile glaucoma. The visual field showed marked defects. And the OCT showed bilateral diminished retinal nerve fiber layer thickness and ganglion cell layer thickness, which were in the range of 60s and 70s and 80s, which is too thin. Actually, I've seen children with congenital glaucoma they had
رحاب الصوت بعد او احنا مش سامعينك.
Can you hear me or not?
Now I can hear you.
Okay. So I start. Can you hear me? Okay, خلاص. So I started treatment with Cozapt eye drops till I scheduled the patient for surgery. I did bilateral subscleral trabeculectomies with right micromycin C and left collagen implant, and the intraocular pressure dropped to an average of 18 and 16 millimeters. 5 months later, I did strabismus surgery. The patient has, as we said before, bilateral DVD without inferior oblique overaction, A pattern intermittent exotropia, and bilateral superior oblique overaction from the Helveston. Superior oblique overaction is superior rectus recession bilaterally. For the XT is lateral rectus recession bilaterally, and the A pattern can be corrected by both the superior rectus recession and the superior oblique. Superior rectus recession has the advantage of correcting the DVD, the A pattern, and the mitosis by reducing lid retraction. However, and superior oblique weakening has the advantages of correcting the superior oblique overaction and the A pattern. However, superior rectus recession and superior oblique weakening would compromise the plebs which were functioning for this child. So they had the disadvantage of compromising functioning plebs and producing fibrosis in the superior subconjunctival space, which would compromise any further subscleral trabeculectomies. So I opted against superior rectus recession and against superior oblique weakening. In fact, it was even reported that a mere superior rectus bridle suture would compromise depths. The other treatment option was an inferior rectus tuck for the bilateral DVD, and it would also correct the A pattern. So inferior rectus tuck had the advantages of correction of DVD, A pattern with no compromise to the bleps or the superior subconjunctival space. However, it would produce more narrowing of the palpebral fissure and would worsen the patient's ptosis. So again, I opted against inferior rectus tuck. The last treatment option was a J deformity inferior oblique anteriorization to correct the DVD together with bilateral lateral rectus recession. Inferior oblique anteriorization would correct DVD with no compromise to the bleps or the superior subconjunctival space and would produce no narrowing of the palpebral fissure or worsening of the ptosis. However, I feared that the A pattern would worsen with inferior oblique anteriorization. Nevertheless, I opted to perform inferior oblique anteriorization because I gave priority for the bleps of the patient. I did bilateral lateral rectus recessions of 10 millimeters and bilateral inferior oblique J deformity anteriorization. There was improvement of the DVD, improvement of the XT, and the A pattern did not worsen. In fact, it turned into a Y pattern. Post-operatively, the child has mild residual XT in the primary position of 16 prism diopters, and in down gaze he's almost ortho, and in up gaze he had a much larger XT, so he has a Y pattern. So how did the A pattern turn into Y pattern after inferior oblique anteriorization? Kushner in 1997 stated that Y or V pattern can occur after bilateral inferior oblique anteriorization as part of the anti-elevation syndrome, which was caused by substantial extortion. Anti-elevation syndrome has ipsilateral hypotropia, limited elevation mainly in abduction, contralateral pseudo inferior oblique overaction, and V or Y pattern, as in this child, which is not the case I'm presenting here. Here's hypotropia in the right eye, limited elevation in all three positions of up gaze, mostly in the elevation in abduction, and he has contralateral inferior oblique overaction in the left eye. However, the case here I'm presenting has no anti-elevation syndrome. There's no hypotropia, there is no limited elevation in the upfield, and there is no inferior oblique overaction in either eye. So this is not an anti-elevation syndrome. So this case had Y pattern after bilateral inferior oblique anteriorization without anti-elevation syndrome and without macular extortion. So how did the A pattern turn into? In 2017, I proposed another explanation for this, which is reversal of both elevating and abducting actions of the inferior oblique after placement in front of the equator, thus becoming a depressor and adductor, producing the Y pattern deviation. On anteriorizing the inferior oblique, now the inferior oblique is in front of the equator, so it will depress the front of the eye, and it will also adduct the front of the eye and not the back of the eye. So its action will turn from abduction into adduction because now it's acting on the front of the eye and not on the back of the eye. So its action turns into depression and adduction. The normal action of the inferior oblique is elevation and abduction. In inferior oblique overaction, there is more elevation and more abduction, producing a V or Y pattern. In inferior oblique recession, this weakens the elevation and the abduction functions of the inferior oblique and corrects V or Y patterns. Inferior oblique anteriorization reverses the actions of the inferior oblique, turning it into a depressor and an adductor, producing a V or Y pattern. So inferior oblique action is elevation and abduction. Overaction causes more elevation and abduction, producing a V or Y pattern. Recession weakens elevation and abduction, correcting a V or Y pattern. Anteriorization reverses the elevation and abduction effects of the inferior oblique, turning it into a depressor and adductor and causing a V or Y pattern. So to conclude, this is a case of DVD with juvenile glaucoma. I opted against superior rectus recession and against inferior rectus tuck. I chose to perform inferior oblique anteriorization, which corrected DVD without worsening the A pattern and without compromising the functioning BEPS and without lid fissure changes. Thank you.
Thank you, Rehab. دكتورة لبنى اتفضلي.
يعني transforming the A pattern into Y pattern, يعني it's not a bad thing so long it is ortho in the primary position and in down gaze, which are the most important positions for binocular single vision. Why not, you think, to do superior rectus and superior oblique through nasal forniceal incision away from the bleb?
I think the approach would be a bit difficult.
It's not that difficult. You can do it, which is going to correct the A pattern and the DVD and also the exotropia. You are going to correct it anyway through working on the lateral rectus.
The superior rectus from the nasal side, I'll have to enlarge my incision a lot, and eventually I'll be going into the superior part of the globe. It will affect the plebs. And actually, my plebs were upper nasal. They were not directly at 12 o'clock. They were upper nasal.
The pleb is temporal, I think.
And I was performing my plebs upper nasal. I never performed them temporal.
So you can approach the superior rectus through temporal incision. I mean, away from the bleb, or otherwise you are preserving such place for maybe you need another surgery, subscleral trabeculectomy in another place. Is that your opinion? I don't hear you. There is a problem with your microphone.
Can you hear me now? Can you hear me?
بعيد الصوت بعيد يا رحاب.
بعيد.
Can you hear me now? Okay. Yes. I preserve the upper temporal quadrant for Ahmed glaucoma valve if needed anytime.
If needed. Ahmed, you have any comment?
Yes, just a few comments about transforming the inferior oblique to a depressor and to adductor. The difference between recession and anteriorization is like 1 or 2 millimeters, because in inferior oblique recession, you would suture the muscle like 2 or 1 millimeter behind the inferior rectus insertion. In anteriorization, you suture it just at the border of the inferior rectus. And both of them are still anterior to the equator, not posterior to the equator. So how would you explain the large discrepancy between the anteriorization and the 2 millimeter recession regarding getting or transforming the muscle into an adductor and into a depressor? We are just talking about 1 or 2 millimeter perhaps, and still both of them are anterior to the equator.
Maybe you can also do the inferior oblique 3 or 4 millimeters behind the inferior rectus.
Yeah, but usually the standard point is like 2 millimeters. So I'd like to think
according to the overaction. Maybe the 2 millimeters would also reverse the action. Maybe just only the recession of 3 or 4 millimeters are the ones that weaken the inferior oblique action.
Okay.
Not sure.
And usually we say that the inferior oblique does not get an innervation in down gaze because it works in gaze. So it should not have an effect in down gaze because it does not receive this innervation in down. It is the abductor in up gaze. So why would you get the problem in down gaze?
Yeah, I didn't get it.
the inferior oblique is not working in down gaze. It does not get any innervation in down gaze. So when the patient looks down, you should not get any adduction because it does not get an impulse. It only gets an impulse, an innervational impulse in up gaze because it is responsible for looking up, not in down. So why does the patient have some esotropia in down gaze? There is no innervation for it.
Why does it not get innervation? Yani it gets innervation wherever it is.
Up gaze because it does not work in down gaze. It is not a muscle working down. It is a muscle working only up.
The normal position.
It's working in the temporal field. It does not work medially, for example. So the inferior oblique is not supposed to work in down gaze. What is working down is the inferior rectus and superior oblique. So in down gaze, it does not get any innervation. So it does not have an effect on the eye alignment.
I have no explanation, but I have the pictures are clear and they show that it turned into a Y pattern, and I have no.
I think it is something mechanical as the anti-elevation syndrome causes the Y pattern. It's something mechanical rather than elevation.
Yes,
I think.
Yes, I understand that anti-elevation you get the problem in up gaze. The problem is in Y pattern. But it is not explained by a problem in down gaze. The problem is in up gaze. You get this.
Yes, right, you are.
That's why I was asking Rehab, because Rehab is explaining it in down gaze rather than up gaze. She's hypothesizing that in the up gaze is still the same. You have no problem. The problem because you got an adduction in down gaze. Dr. Hela, Dr. Haytham, would you like to?
I would like to add some comments. If I.
Yes, Haytham.
Can you hear me?
Yes, go ahead.
أول حاجة أنا شايف إن regarding the horizontal alignment هو post operatively كان في residual XT وده متوقع طبعا لأن two muscles يعني bilateral recession مش هتصلح 60%. If ask Rehab why didn't she add one medial rectus strengthening؟ ده السؤال الأول. الحاجة الثانية اللي هي بتقول إنها بعد العملية في some adduction بعد الانتيريزيشن في some بتتحول إلى some adduction. I approve this. أنا حقيقة أنا بشتغل كتير قوي antirization بس أنا مش بعمل J deformity. أنا بعمل حاجة اسمها inverted T deformity. يعني it's my own invention. I can explain it in a further meeting يعني. لكن دايما بكومباين الانتيريزيشن مع some resection of the inferior oblique as well. ففعلا بلاحظ في بعض الحالات في a very mild deficit of abduction which favors اللي هي بتقوله ان هي فعلا بتعمل some adducting effects. دول يعني المين كومنتس اللي كنت عايزه اضيفهم يعني.
Maybe this because you are doing resection of the inferior oblique, not just anteriorization. Yes.
Yes, it's a very mild dissection. يعني هي مكان الكلامب.
How many millimeters?
Maybe 1 or 2 millimeters. مكان الكلامب ما هيش a big dissection بس أنا بلاحظ فعلا هي ليها some adducting effects. اللي برضو النقطة اللي يعني نفس رأي أحمد إن هي الأكشن بتاعها innervational wise it acts only in up gaze مش in down gaze. فهي ممكن تبقى explained on a mechanical basis بقى.
Mechanical on mechanical basis.
دكتورة هالة.
دكتورة هالة.
Do you have any comments?
For the 10 millimeters recession bilateral, I followed the tables of Kenneth Wright, and it said that for 60 prism diopters, we would do bilateral lateral rectus recessions of 10 millimeters. And in fact, I had the residual XT, but only of 16 prism diopters. And for the inferior oblique resection, I actually clamped the inferior oblique before this insertion, before taking my sutures, and I give myself enough space to cut the muscle. So actually, I do a resection just for the sake of protecting the macula and not for the sake of actually performing a resection. So the anteriorization was associated with some resection.
Nice case to have, very mind stimulating.
can I ask a question
regarding the glaucoma?
regarding glaucoma? Can he has such a huge field effect with a cupping of only 0.4? Or this is because he's a young child, so the field is not reliable. And he's only cupping 0.4 and he has a very bad field to the extent that he realized the field effect كمان اللي هو
Yes,
is it
but
common?
the field effect is true because the retinal nerve fiber layer thickness was much diminished. I had cases of congenital glaucoma and they had 0.9 discs, cup disc ratios, and the retinal nerve fiber thickness was 100. So 65 and 70 and 80 are really bad. Maybe the optic disc stretch in the very young ones, the congenital ones, so we get a very large cup disc ratio despite good retinal nerve fiber layer thickness and good field. When they grow up, I performed field for these 0.9 cup disc ratios and they had good field. So maybe the large cup disc ratios were just stretching effect in the very young age. And as this child, the disc could not stretch because he was old. So maybe that's why he did not get a very large cup disc ratio. But the field effect is true because it's emphasized by the thin retinal nerve fiber layer thickness.
Okay, thank you, Dr. Rehab. I'm just, we meet a lot 0.4 cupping and we deal with it lightly, so we have to give that much more attention. Thank you.
I just want to ask, what about, if you're suspecting whether this damage is due to glaucoma or not, wouldn't you want to manage him on medical treatment for a while, or medical treatment is not an option?
It's an option, but not for lifelong. You cannot give a child medical.
At least it will prolong the, it will, أولا give him more chances and delay the what you have to interfere at such an age, especially that he's 5. I think his mother could be compliant. I don't know. Maybe if we put him on medical treatment for some time, we can delay performing surgery. And also, I don't know if you do that, would you have performed the surgical procedure you wanted on strabismus? And then maybe later on, maybe even a few years later on, do him glaucoma surgery?
Yeah, this is an option, and I gave medical treatment for 2 months. The intraocular pressure was 18 in one eye and 20 in the other eye. But I felt it's impractical to stay on medical treatment, so I opted for surgery. But maybe others would give medical treatment for much longer periods of time.
You didn't consider angle surgery?
Rehab, yes, I was just about to mention this. Yes, Rehab, it's such an interesting case, actually. As Ahmed said, it's mind stimulating. But actually, so long as that you had strabismus at the very first place, in addition to juvenile glaucoma, wouldn't you think of performing an angle surgery instead of subscleral trabeculectomy?
Maybe I would, but at that time, and I was too big for angle surgery. Maybe the Shams canal would not allow trabeculotomy, but maybe I would change my opinion if I try to do it now.
Yeah, because we perform angle surgery in even up to 10, 12 years. We still perform angle surgery sometimes.
Especially, you don't have a very large
corneal diameter, yes.
Yes, corneal diameter and a very large globe. In such situations, you may find the Schlam's canal completely collapsed. But in the 11.5 millimeters, you can find the Schlam's canal okay, and you can do angle surgery.
Yes, he won't be having stretched limbus. So I think it can make angle surgery an option, actually. Yeah.
Yes, and there is increasing trend now in using angle surgery even in adults. So
yes.
Would anybody like to add anything? Okay. I want to thank you all for being with us tonight and some very interesting cases. And I hope you enjoyed it as much as we did. And we look forward to seeing you in our next scientific meeting, inshallah. Thank you very much and good night.